So let's move on to airways. Um, Talking about air moving in, how we actually do that by changing the size of the thoracic cavity. And now we need to talk about how the air actually moves to the lungs. So the air is going to flow um, through the nose or mouth or both, depending on how you're breathing, past the vocal folds in the larynx. This is right here. Oh, need to go to laser pointer again. There we go. So here's the larynx right here. We're going to talk about that much more in the very next section. But for now, here it is. So air flows through the mouth and or nose, down past the larynx, and then down into the trachea. The larynx, by the way, is bounded by the hyoid bone right here and the cricoid cartilage right here. Everything within those is the larynx. The cricoid cartilage is the first cartilage ring of the trachea. It's also one of the cartilages of the larynx. So it does kind of dual jobs. it's the hardest working cartilage in speech, I guess. So the rest of the trachea has all these other cartilage rings. There's something special about the cartilage rings in the rest of the trachea, though. So the cricoid cartilage is completely solid. It's a solid cartilaginous ring like that. The rest of them are kind of open in the back. Like see this, the back or the front or different places around. So you can see this where the cartilage ring kind of like comes towards the other ones and it doesn't quite close onto the other ones. This is kind of like really cheap. You throw like 25 cents in a machine. Like for me, when I was a kid, it was the Filiberto's by my house. And you put 25 cents in, you turn the thing, and you get like a cheap yin yang ring out of it. Or Homie's action figures, if you were lucky. But sometimes a yin yang ring. And the back would open a little bit so it could fit anyone's size of finger. And that's kind of like what these cartilage rings are doing too. They're open, they don't completely close. There's a reason for this. That allows for the trachea to move and flex. It offers like a balance between complete rigidity, which would be good for keeping the airways open all the time, except that it wouldn't be good for allowing your neck to move and flex because it would break. And then that would end the fun very quickly. And then also if you had no rigidity at all, and it was just a completely flexible airway, just tissue, then it's possible that it can collapse all the time. And again, no fun. So what you want is a little bit of, you want some rigidity, but not too much rigidity. And this flexible cartilage that can bend and flex in all sorts of different ways is the optimal balance. So you can see that there's parts, there's a ring here, but in between there isn't, kind of like a bendy straw. And then here you've got places where it should end, but it actually doesn't, and that allows it to get larger and smaller. So there's all sorts of interesting ways that the trachea has some rigidity, but not complete rigidity. But just think cheap jewelry and bendy straw, all these things that kids love, that's how your trachea is made. Cool. The trachea is going to move, the air is going to move inferiorly down the trachea to this thing called the carina right here. The carina means boat keel in Latin. I guess presumably because it looks like a boat keel. Here's another view of it right there. And then it's going to branch off to either side of your lungs, to your left lung or to your right lung. The right bronchi shoots off at a little bit of a, let's see, this is actually going to be reversed. So you're looking at it slightly reversed. The right bronchi to like your right bronchi is actually what we're seeing here on the left. This is a person that's like looking at us. So yours is going to be at a 45-degree angle. I was going to ask you why you think that is, but I actually have it on the slide. So I guess don't read that yet. Why do you think the left side uh, bronchi is a little bit shallower of an angle? It's to accommodate the heart. That's right. Pretend you never saw this here. So you've got a heart on the left side right here. Is this left? Yeah. This is the left. You got a heart here. So you only have two lung lobes on the left. And again, remember, this is reversed. So this is actually the left of the person that we're looking at. There's a heart here. And then this branches off, and there's only two lobes of the lung on the left side. On the right side, you have three lobes because there's no heart over there. So here's lobe 1, lobe 2, lobe 3. And then what's really interesting about this, we're going to talk about this way later towards the end of the class, about aspiration-induced pneumonia. Most aspiration-induced pneumonia happens in the right lung. And the reason for this is because of this 45-degree angle. This one to the left, stuff doesn't come down here and then take off this way. You usually can cough things out if it's coming down towards the left bronchi because it doesn't like take as much of a direct turn. But if it goes to the right, it's much more of a direct pathway downwards. And so it's more difficult to cough things out that are going down that airway. If you aspirate something and it makes it that far down, chances are you won't be able to cough it up if it's in the right. Well, not chances are. You're less able to cough things up from the right lung because of this angle. And so most cases of aspiration-induced pneumonia happen on the right lung. That's not to say they can't happen in the left lung. Certainly they can. And other types of pneumonia have no preference, but aspiration-induced pneumonia tends to happen on the right side. And again, it can happen both, but it tends to be the right. Okay, let's talk about further down. After we go branch to these two bronchi, we get to these little bronchioles. Afterwards, smaller and smaller and smaller until we get to the very end where we have alveoli. So you may be thinking, if you've had 205 and you've learned things, or phonetics, and you've learned things like the alveolar ridge, you might think it's really strange that the alveoli in your lungs and the alveolar ridge in your mouth are called the same thing. Well, alveolus in Latin means sac. So actually, when they say alveolar sac right here, you're just saying sac. But that's what it means. An alveolus is a sac. And so here, it's little air sacs. And in your mouth, it's tooth sacs. If you don't have teeth and you look at the alveolar ridge, it looks like a bunch of like little sacs for teeth that you can just like slot teeth in afterwards. Most of this is done on like, cadavers originally when they're naming these things. So it makes sense that there's no teeth in there. It's not like they were looking at a totally intact person and they were like, I bet your mouth has like teeth sacs under your teeth. It's not like that. Anyway, alveolus sac. And that's why you'll see this term come up in several places that seem unrelated, and they are, because it's just kind of describing the shape of things. So in the lungs, all the way branching down, smaller and smaller and smaller, we get to the end of the tubes, and at the end of the tubes we have the alveoli, the little air sacs. What's really interesting here is that what's also happening, if you look at the arteries are branching and getting smaller and smaller and smaller here as well. They get so small that oxygen and CO2 are able to diffuse through the alveolar membrane. It's so small and so thin that oxygen and CO2 can diffuse right through the membrane. Usually in other places of the respiratory system, this isn't happening. It's just happening in the alveoli. So very small capillaries. The sac structure, this like globular spherical structure of the alveoli, is important because you maximize your surface area. The more globular you can get, the more surface area there is. And that means with more surface area, there's more place for blood vessels, little tiny capillaries, to cover the surface of the alveoli. The more surface area there is, the more blood vessels that can cover that surface area, and the more efficient your gas exchange is. So remember, respiration is the power source for speaking, but it's already its own thing. Like, we've just hijacked that to be able to talk. We're using it by throwing vocal folds in the way. But it was already there doing something, which was giving us oxygenated blood to power our muscles. So we've just hijacked it to be able to talk. Way before humans and spoken communication, there was respiration. So it's just, we're using it. So what's going on at the bottom of this is you take oxygen, blood that's been used up, it's depleted of its oxygen, now it's full of CO2, travels down to the alveoli. The CO2 diffuses into the alveoli. The oxygen that you've breathed in diffuses out of the alveoli and into the blood. The oxygenated blood then goes back to the heart to be redistributed to the rest of the body, and the CO2 gets exhaled, and then you can breathe in more oxygen and restart the cycle all over again. Pretty awesome. I think it's cool. I don't know. I think it's neat. It's a really great system. It's like pretty efficient. So let's talk about the lungs at a more macro level of lungs. We've gone real small. We've looked at the alveoli. Now let's pull back and look at the lungs in general. Here's the lungs. There's also a heart in there, bonus heart in addition to lungs. This is without, obviously, the rib cage, and there's no diaphragm at the bottom. It's just the lungs and heart. This is, how do I want to say this? The only thing that's attaching the lungs to the rest of your body is the trachea. That's how I'm going to say that. It's just one connection point. So right down here, that's been removed in this image. But you have your trachea that comes down. And that comes up, it connects to the larynx. The larynx, of course, connects to like all this other head stuff up here. That's the only place where your lungs are connected to the solid structure of the rest of the body. It's just kind of like hanging. Imagine a bell. They kind of look vaguely bell-shaped anyway. So imagine a bell, and it's just held at one place so that it can actually ring. It has to be able to move and do its own little bell things, so you can really only hold it in one place. If you hold the bell with your entire hand, it just goes dunk. It doesn't actually do bell stuff. This would be true of the lungs as well. So if the lungs were attached to the thoracic cavity, they wouldn't be as efficient at filling with air and pushing air out of them. So what's actually going on is that the lung tissue, the outside lung tissue, this that we can actually see in this picture, this is covered in something called a pleural lining, and that prevents abrasion between the lungs and the thoracic cavity walls. So it's kind of just like, it's like a lubrication to allow the lungs to move nicely inside the thoracic cavity. There's a disease called pleurisy, and what it does is it's an infection of the pleural lining. You end up getting like all these adhesions between the lungs and the thoracic cavity with pleurisy, and it makes it really painful to breathe because your lungs are like stuck to the inside of the thoracic cavity. So as you're breathing, it's like pulling the lungs apart. which isn't what they do in the body. What happens is the thoracic cavity expands, and then the lungs inside the thoracic cavity expand inside of there to fill them, but they change shape on their own. Let's take a look at this. So I've got a few videos that I'm going to bring up. Okay. And we'll make sure this is muted. Yes. All right, so this is a machine that essentially, before I let this guy open up the machine, what you're looking at here are human, well, it's probably pig lungs in this demonstration, but the machine's for human lungs. You take the lungs out of the body. This can be done for any reason why you need to do surgery, like in the thoracic cavity. So let's say heart surgery, or maybe removing cancerous tissue from inside. Any number of reasons. You can remove the lungs and place them into this hard shell. What's going on inside the hard shell is the pressure is changing. There's actually a bag inside the hard shell. The hard shell is for protection. The bag inside is changing its shape. So not the lungs. They're not forcing air into or out of the lungs. What they're doing is forcing air into and out of the bag that's around the lungs. So they are adding air to the bag to press on the lungs, or they're removing air from the bag to make the lungs inflate. And so they're still functioning in the same way that they should be inside the body. They're replacing the thoracic cavity with just a different covering over top of the lungs that's changing size and therefore changing pressures, and the lungs are going to go along for the ride with the changing pressures and change shape and pressures themselves. So we're opening the hard shell, and you can see the bag inside. So this machine allows the lungs to function as they do inside the body. This means that the lungs can be removed from the person, but they're still like attached to the person, right? So like you've still got the patient's blood flowing right here to the lungs, into and out of the lungs, so that it can be regenerated with oxygen and get rid of CO2, just like it would in all of us, anybody that's watching this right now, and me too. I have natural lungs. I'm not a robot. And this is doing exactly that. What's great about this is you don't have to worry as much about, so if you do have to remove these, as soon as you remove them from blood flow and you start putting them on ice and stuff like this, the surgeons have a limited amount of time to be able to work to try to do what they need to do inside behind the lungs. When you attach the lungs to this machine, you give yourself a lot more time because they're still functioning like they would be in the body. The lungs don't know they're not in the body. Obviously, they need to be hooked back up to the person at some point, but this is going to buy you some time. The blood is still moving in, the blood is still moving out, oxygen's still moving in and out to serve the blood of the patient's body. It's a much better situation. Okay, so we'll watch these lungs for, and that's it, because we don't actually need to see what's going on with this. So what this guy's doing is he's got a small piece of sheep's lung and a syringe filled with just regular air. He's going to insert the syringe into one of the larger bronchioles that he can find in this little piece of lung and put the air into it. And what you're going to see is the way that the lungs inflate like they do inside the body. So there's the bronchiole, and then the air goes into the bronchiole and into the alveoli. Isn't that so strange. This last one is similar. These are full set of lungs, full set of cow lungs that are connected to an air pump. And so the entire pulmonary system the entire respiratory system is now getting inflated by this pump. So sort of the same thing that we saw on the small scale with the little piece of lung that you could see up close. This is the entire set of lungs. And this is essentially what's going on inside of you right now too. Cows are much bigger. So of course their lungs are going to take up more space. But yours are taking up quite a bit of space too. Especially at the beginning of the lecture when I was having you take in full breaths and then push it all the way out. Very similar to what's going on here. Lungs are crazy. Okay. So now we go back to our movements and forces. This is why I wanted to keep this whole lecture together, because I wanted to kind of prime you with the movements and forces, tell you all the different things that are like in a large scale way. We're gonna have to go back and learn all the muscles and the bones and stuff like that later, but kind of a big overview of what's going on inside the lungs. And then we're gonna talk about what's actually going on with pressure differentials inside the lungs. It can get a little confusing, and so it needs a little bit of scaffolding before we get there. I've already talked about this. The breathing apparatus is made up of pulmonary apparatus and chest wall. They're not connected. The diaphragm separates the abdominal wall and the thoracic cavity. So really the thoracic cavity is just up here. The diaphragm forms the border between the abdominal contents and the thoracic cavity. We know all this. We've talked about this. Okay, so for inspiration, we've got active muscular force. For tidal volume, it's mostly just diaphragm. It might not be diaphragm only, but it's a large part diaphragm. For forced inspiration, it's going to be all the muscles of inspiration. Everything that can enlarge the thoracic cavity. So here is the model of what's going on inside the lungs. We're starting at equilibrium. This is just at tidal exhale, right? We're just sitting. We've exhaled. We haven't inhaled yet. Everything's equal right now. All the pressures are equal. The pressure in the lungs is equal to the pressure in the thoracic cavity, is equal to the pressure outside, the barometric pressure outside. They're all equal. And then you breathe in. So what you do, you breathe in, diaphragm moves down. It could be some other things as well. It could be that the rest of the... Well, let's go back. Just in case you don't, if this isn't making a ton of sense to you. The trachea is right here. This little straw-looking thing, that's the trachea. It goes into the lungs. The lungs are only connected to the rest of the body by the trachea. Up here, this is the thoracic cavity. The diaphragm is this line separating them in the middle. And then you've got abdomen and other stomach goo down here. Again, equal. You breathe in, diaphragm moves down. A little bit of an oversimplification. Sure, there's other muscles and things that might be changing. We can enlarge the thoracic cavity, but just to simplify it and to look only at the diaphragm, I think you'll still kind of understand what's going on. So diaphragm moves down. The thoracic cavity has gotten larger. Remember, volume and pressure are inverse of one another. So if the volume gets larger, the pressure has to get lower. There's now less pressure. By the way, as we go through these, I'm going to show these to you in steps of what's happening. It's all kind of happening just right at once, right? So like I'm breaking it into steps to break it down so you can see what's happening. But as soon as you start breathing in, it's all just like a cascade. So you breathe in, the diaphragm moves down. A little bit of positive pressure on the abdominal contents, so the stomach is going to want to move outwards. You've got negative pressure now inside the thoracic cavity. The negative pressure inside the thoracic cavity is what is going to want to pull the lungs into this space. Think of it as like anytime you see negative pressure, it's a vacuum. So you've expanded the thoracic cavity, and the lungs are going to want to expand to fill that space. And so they do. They expand to fill that space. Now the lungs have expanded. Lungs have gotten bigger to start filling up the thoracic cavity. And what does that mean? Now the lungs have negative pressure relative to out here. They still continue to expand. Negative pressure relative to the outside. And when you have negative pressure inside of a place and a whole bunch of air outside, what does that mean? The air is going to rush in. So when you breathe in, thoracic cavity expands. Lungs expand to fill up the thoracic cavity. And that means pressure is decreasing inside the lungs. Pressure is decreasing inside the lungs, but it's still larger outside. So it comes from the larger place through your mouth and nose into the place that was low pressure. And then, when you hold your breath at the top of an inhale, tidal or otherwise, it's all equal. It might not feel like it's equal because it feels like you're holding your breath, but the pressure is equal. What you're feeling when you hold your breath, breathe in and hold your breath, what you feel is the muscles pulling your thoracic cavity to be wider. You feel your diaphragm being pulled down. You feel all the muscles in your thoracic cavity expanding. But I can hold my breath and have my mouth open, and the air isn't just like rushing in or rushing out. That means the pressure, the air pressure, is equal. So when you're holding your breath, air pressure is equal. If I ask you a question on the exam about this, the air pressure is equal. Even if it feels like you can feel tension inside your body when you hold your breath, it's muscular tension. It's not air pressure. Okay. Now, an exhale. You've held your breath for way too long. You want to exhale. Yeah, expiration doesn't always require force. You can use forced expiration, blah, 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 blah. Let's keep going. So you allow your diaphragm. Okay, let's go back. Let me show you. Diaphragm's here. And now it's moved up a little bit. So now it's starting to push on the lungs. The thoracic cavity, you've got this big breath, and then you're going to let your thoracic cavity sink. It's going to get smaller. So what's happening is now the thoracic cavity is pushing on the lungs. We're increasing pressure. Decreasing volume, which means pressure goes up. So it's pushing on the lungs. Well, the lungs are starting to feel that pressure, and they're going to want to get smaller as well. So they do. And that means the pressure inside the lungs gets greater than the outside air. When the pressure in the lungs is greater than the outside air, the air wants to move out. And so it does. And then you're back at the end of an exhale, and again at equilibrium. So all this complex stuff that we talked about, all the complex stuff, everything that basically keeps your body going, right? Like the heart is necessary to pump blood to your whole body. If you don't have blood pumping to your body, you die very quickly. But the blood has to be oxygenated. So the lungs are extraordinarily important for the heart to do its work too. And it's all accomplished by just a few muscles being active only for the inhale. For tidal breathing, mostly the diaphragm, maybe a few of the other muscles of inspiration, and it works. You get the gas exchange, the oxygen goes in, the CO2 goes out, and it's all accomplished by just pressure differentials changing the size of the thoracic cavity. That's it. It's so simple. And then we throw some vocal folds in the mix to hijack the exhalation that we're already doing. You're getting rid of this waste product, and we're using the vocal folds to pop into that waste product coming out and use it to make speech. Very cool. We've talked about the movements of the abdominal wall. Basically, when you breathe in, your stomach moves out. When you breathe out, your stomach will move in. Because there's a finite amount of space inside your body, and when the thoracic cavity increases in size, there's less place for the abdominal contents to go. When you do a forced exhale, your abs and obliques will push in on your stomach contents, which will force them up into the diaphragm, and then just like shoot all the air out of your lungs. Next, we're going to talk about bones.